Good afternoon, everyone. It is 1 o'clock, and we're going to go ahead and get started. My name is Kathy Hull, and I am the CHNA and New Services Coordinator for ICAHN. Welcome to our first webinar on the Rural Health Transformation Program and the funding opportunities that are coming through the ICAHN network. So, we're going to go ahead and get started. We have some time for Q&A at the end, so hopefully we will be able to get to questions and kind of get you on the right track for what is happening at this point in time with the Rural Health Transformation Program funding via ICANN. So I'm going to share a screen. All right, so hopefully you can see my slide that says Rural Health Transformation Funding Opportunity, and this one is focused on disease prevention. Again, this is part of a partnership between the Illinois Critical Access Hospital Network and HFS Illinois through a program that they are calling Illinois Rural Health Transformation. So we're going to go ahead and, if I can help my slides move forward, talk about the agenda real quickly. We're going to talk a little bit about some basics of rural health transformation and then dive deep into the hospital disease prevention program itself. So what is RHTP? I'm sure you know quite well that through the Center for Medicare and Medicaid Services, the U.S. Department of Health and Human Services, there is financial awarding of $193 million awarded to the Illinois Department of Health and Family Services to be distributed across the state of Illinois to various grants. The program goals of the program overall: transforming rural healthcare, overcoming geographic barriers to care, building a resilient workforce. And you can see that those three main initiatives are going to be supported by what you're going to see coming through ICANN in our funding opportunities. So ICANN has three supported grants, the one you are going to learn most about today, which is disease prevention, but we also have two others: workforce development and technology transformation. And I'm going to ask Liz to jump on just 1 second and talk about the workforce development program.
Sure. Hi, everyone. I'm glad to see everyone. And yes, I'm glad to talk a little bit about workforce development. And I'm not going to take much time here, but to let you know that there is a workforce development component, and there are funds that are going to be going to the hospitals. And it is going to be designed for three things, really. We're going to be looking at recruitment, retention, and then educational awards. And with that, it's going to be recruitment of positions to your hospital. And we are really leaving that open to what your hospital needs are. That we'll talk more about that tomorrow. But we really felt very strongly that each hospital is unique, and that not all hospitals necessarily have a doctor or a nurse shortage. It might have a shortage in lab. It might have a shortage in something in allied health, or another specialty that we felt like that we wanted to leave that open to what your hospital needs would be. So we have that. We also have retention. We felt like there needed to be money to be spent for retaining those employees, those loyal employees that have been with you for a long time, that it's not just money for going out and growing your own and finding new people, but rewarding those people who've been loyal and been with you for a long time. And then also some money for growing your own, and having money for educational awards, and being able to help people that maybe are your employees, are part of your community, that really want to either shift positions, go back to school and learn a new skill, or are a senior in high school and want to take on a healthcare position, that this would give you either more money than what you are able to give currently, or open up new lines of resources to give those folks money. Just a couple of other things that I will mention with this, there is a 5-year work back commitment with this workforce money with an individual gift. We'll talk a little bit about this tomorrow. So I encourage some creative thinking when it comes to how you want to design your projects, so that maybe some of these projects with retention are more about onboarding and leadership and education, and maybe not about a individual gift. But we're trying to make the application fairly simple. But some things we're going to be asking you about and to be thinking about is your turnover rate and your time to fill position rate. So that's basically it. We are going to be doing the presentation at 9 a.m. tomorrow and then at 2 o'clock on Wednesday. So please join us to learn more.
Thank you so much, Liz. Brian, would you like to speak just a moment about the technology transformation?
Yeah, thank you, Kathy, and good afternoon, everyone. I'll be brief. I appreciate Kathy giving me a couple minutes just to introduce what we have planned. Just kind of a very general overview of what we have planned for the Technology Transformation Initiative. So I know the Tech Transformation Initiative is maybe slightly delayed compared to the workforce development and the disease prevention initiatives. We will be having an education session just like we are today with this disease prevention session education. We'll be having something very similar for the Technology Transformation Initiative in the coming weeks, and we'll have more information and specific dates and times to share with you on those. So one reason for the slight delay compared to these two initiatives that Kathy and Liz are implementing is through conversations with the state, we really wanted to initially do some data collection with hospitals, just to get an idea of where everyone's at from a tech standpoint. So we are in the process of soliciting proposals from vendors to conduct a digital readiness and needs assessment with each hospital in the program, again, just to collect some baseline data, which will then ideally help inform hospitals on where funds may be most beneficial for tech projects that you will be applying for eventually. And then another component, another step that we are going to be soliciting proposals for here soon is to identify a vendor that's going to do a deep dive or a deeper dive than what would be done with that initial digital readiness and needs assessment, specifically on cybersecurity, to identify where each hospital is at and their cybersecurity capabilities, and then working with that vendor or a different vendor to implement cybersecurity solutions in hospitals that want them and need them. So we'll have more information on these projects here very, very soon, but just wanted to give you a brief idea of where we're at on that and let you know that more information will be coming soon. And I look forward to working with everyone on it.
All right, thank you so much, Brian. We're going to go ahead and just try to move ahead here. So this is the funding timeline that we received from the state of Illinois, and it's a little bit off, but it gives you a really generalized idea of where the funding is coming from. The grants that were to ICAHN from HFS were signed on the last day of July, so implemented August 1. So we're not as far off as you might think. The timeline for year one spending is through September of 2027. So we'll talk more about timeline in as we kind of go through the presentation. So initiation design, that has been going on for several months before June, but training and prep here July and August. Applications and awards, we sincerely have the belief that we will give you the application in the month of September. We are working through UNA to get that put into their format today, and so hope to get that out to you ASAP. And then the actual granting to you, the dollars coming to you, again, to be determined fully, but we believe it will be in the month of October. So let's talk about disease prevention, the grant itself. $14 million has been allocated to this specific bucket of granting. And again, real-time budget, September of 26 through August of 2027. This is for all critical access hospitals and rural hospitals designated rural by CMS. So very distinct guidelines, again, looking to improve patient outcomes, promote population health. This is based on your own needs. So needs identified in your local health priority resources like your CHNA or your county I-plan or some other sort of a health needs assessment. With the disease prevention grant only, the facility should have a local health department partnership. So that's been something that when we initially started talking about this granting was not a must-have, but as we have kind of fleshed through the grant, this has become a must-have part of the program. So you will have to have some sort of connection with your local health department in your disease prevention granting. Overall goals of the disease prevention grant, again, improving patient outcomes, quality of life through better disease control, reducing healthcare costs overall, returns to the ER, high cost utilization of services, putting access to preventative services more at the community level, empowering patients to know more about their own individual health and self-management, looking for ways that we can sustainably deliver healthcare through models that have national benchmarking and that are aligned with national outcomes, and then supported the identified need, again, of each region or identified population. And then the last goal is reducing redundancy. So there are supported activities. It could be a one-time educational program, meaning you could have someone come in and talk about X disease to your providers, your nursing staff, your team. It could be a new program or new positions, or it can be an expansion of existing programs or positions. Again, priority will be given for those who do develop a partnership and local health department partnership is an expectation of this grant. The program that you implement must be grounded in some sort of peer-reviewed research, established public health frameworks, etc. So you can't just make up a program and has to be given with some data background. And then you will have to demonstrate your need, provide some benchmark data and your anticipated impact. Allowable use of funds. So staffing, if you're hiring some new role or if you're expanding upon a role. Let's just say you wanted to hire community health workers to go out and visit people in their homes, or you wanted to hire or maybe take a current RN and get some specific education to improve them for certified diabetic educator or something to that effect. Benefits that go along that are part of this, supplies and equipment, travel that is related to the grant specific activities, costs related to the creation and expansion of your program. That includes, again, external vendor services if you require an external vendor to be a part of that. Minor renovations or alterations that are clearly linked to the program goals are acceptable, not new buildings. So don't think you're going to buy or renovate something large, but let's just say, and this is strictly an example, if I were going to focus in on mental health and I wanted to take one of my existing ER rooms and make it into a safe room, that could be a potential renovation that would be approved. Again, training, coordination, and staffing to support your chronic disease prevention and management activities are all allowable. Things that are not allowed, anything that happened pre-award date. So anything that happened prior to your award is not allowable. Again, new construction, duplication of payment of any kind, so you can't double dip and get paid from Medicare or Medicaid, and also then take this as payment. So anything that is a billable service, you must continue to bill for. You also cannot double dip if you're grant supported. So if you already have something that has grant support, you cannot also have this grant support that. Clinician salaries or wage support if you have no compete contractual limitations. Currently employed positions, so you can't say I'm going to pay for 3 RNs that already exist. Capital expenditures for improvement to land, buildings, or equipment. No kind of research or development, no kind of lobbying or any sort of influential activity on legislation. No promotional items, memorabilia, gifts, etc. You cannot use it for marketing or PR for your entity. You can use some of the funding to market a specific part of your program. Let's say, again, you're going to start a diabetes management program. You could use it to market that specific program. And then meals, unless, of course, they are a part of a specific educational event. There are 4 tiers of funding. Tier 1 is less than $100,000. There'll be approximately 40 awards. Again, these numbers are very flex in the grand bucket of funding as long as the funding comes out in the end. Local and community programs, about 18, that's 100,001 to 250,000. Regional programming up to 350,000, and then large program up to $500,000. There is data collection and comparison. That is an expectation. You will be required to have quarterly reporting that will include activities, budget, and outcomes. So that will be something that will be an expectation. Again, dates for those will be determined end of the quarter. They'll be due to us because we then have to report out to HFS. So I'm just going to go through some examples. And this is purely made up. Please don't take this and go, this is what I need to do. If I were going to write a program for the chronic condition of type 2 diabetes in adults in my local community, here's how I wanted to do it. I want to strengthen coordination between the hospital, the rural health clinic, and the local health department, targeting patients with poorly controlled diabetes or those who are at high risk or previously diagnosed as pre-diabetic. I'm going to have an education, self-management, support, and access to care. That was kind of the broad look at my program. My identified population is adults with type 2 diabetes or prediabetes who were recently discharged from the hospital with a diabetic-related condition identified in the clinic or in the health department clinics. Again, my goal would be to look at underserved and rural populations, which would mostly be the populations that we serve, limiting their access to diabetes education. I'm looking to include 50 to 100 participants. It is based on data. The CHNA showed the specific data, and you'd have to show your data and some semblance of a benchmark, where that benchmark came from. Partnership would be a necessity. Community partners that contribute to the health needs assessment were the health department, the mental health cooperative, my county ministerial alliance, etc. Again, the project tier would have to be selected. This one would be a project tier 1, less than 100,000. Patient enrollment and risk stratification. There are key components of the program. So identifying eligible patients through hospital discharge lists, primary care and clinic referrals, again, collecting some baseline assessment data, BMI, hemoglobin A1C, blood pressure, medication adherence, etc. This will be a nurse-led program. I plan to hire a part-time registered nurse to serve as the care coordinator who will do the following things. I'm also going to provide some diabetes education and self-management workshops, 6 to 8 sessions per year held at various locations. See the topics that would be included. There would be some remote or low-tech monitoring provided. Patients who did not have covered insurance for glucometry and supplies, as well as logging, and then some data given back for us to review. Again, the evaluation and reporting would be pre and post measurement of the A1C, the emergency department utilization for those individuals, and then self-reported confidence with their disease management, and then a final report would be prepared. Community partners, in this example, the hospital and its rural health clinics will provide patients with blood glucose meters and supplies if not covered by insurance, and establish a monthly phone check-in for each patient to review their data and identify early intervention. The clinic provides routine care. It doesn't offer a structured chronic disease self-management program. The funding will expand the service rather than duplicate. That's another big key to HFS's initiatives, is It is not to duplicate services, but to either expand or to create new services. Partnership with a local health department provides educational classes. This is just an example of what the budget might look like. Again, a 0.5 nurse, diabetes education materials, glucometry supplies, space rental, etc. The evidence-based approach would be based on the National Diabetes Prevention Program. It is for type 2 diabetic or pre-diabetics. It aligns with the Healthy People 2030 goal of DO1, reducing the number of diabetes patients diagnosed yearly. The anticipated impact, the baseline 42% of the enrolled diabetic patients have a controlled A1C of less than 8, and the target will be to increase that to 60% by the end of the period. So again, that is a very quick review of a potential program. So let's talk about real life. When and how can I apply? I wish I could give you an exact date. I can't do that yet. Applications will be in ICAHN. If you applied for the hospital transformation granting, you will be familiar with ICAHN slightly. This, however, will be a new ICAHN platform. It will be ICAHN ICANN, not ICAHN HFS Illinois. So you will have a separate login for this new ICAHN system. Good news, though, is that future granting through the ICANN will be through this electronic system as well. So no more paper project reporting. Applications, the date, we believe it will be in the month of September. We are working with ICAHN currently to get those applications uploaded, so you'll have quick access to that. Applications will be open for approximately 10 working days. We will be posting technical assistance hours once the funding process opens in ICAHN. Again, the funding timeline is to be determined, but we have a target of getting those funds out to you in the month of October, so you have a maximum amount of time to spend that funding. We know that this year one is a strange, shortened turnaround time, so trying to get those funding into your hands as soon as possible. Again, for year one, disease prevention, everything must be spent by 9/30 of 27. So you'll have a little over a year and theoretically to expend those funds. So I am going to stop sharing, and I know that was super duper quick, but I'm going to stop sharing and see if anybody has any questions or things we could explain better or differently to you.
So is mental health considered a part of disease prevention?
It is. If you had mental health in your community health needs assessment or your I-plan as an priority, then yes, you can select mental health.
Thank you.
You bet. We will be sending you the slides as well as a Word document that has the questions on the application and the budget template. Unfortunately, I don't have permission to attach those to this this particular Teams meeting. So I will figure out with Liz how we get the information out to y'all, and we will get that turned out ASAP to you. So you'll have that in hand. Again, there's a Word document that will give you the questions that will be in the ICAHN so that you can start thinking about that today.
I would encourage you to start answering those questions in a Word document. And so when ICAHN is open, all you have to do is kind of cut and paste. It would make it a lot simpler and faster.
I agree, Liz. And when we did our ICAHN with HFS, we also did that because there were times when ICAHN would not save or throw you out, and it was an unfortunate just fact of life. So I would recommend getting that into a Word document. So I've got a couple of questions from the chat. Is there an approved vendor list or programs, or can we use anyone? You can use who you would like. If you are looking for vendors or individuals to help you with that, I'm sure that ICAHN can provide you with some of our key partners that would be available to work with you. Marcia asked, is this a multi-year grant? Well, that's the $6 million question now, isn't it, Marcia? Because in theory, the answer is the grant will be open for 5 years, but every year is a new opportunity. So this grant cycle, year one, will be truly a single year opportunity that you would have to spend the granting in that true year one, meaning, I hope I'm answering your question. This is not a grant that stretches over 5 years and you have 5 years to spend, but it will, in theory, have 5 complete years of the granting. And yes, your focus could be different for every year. Yes. Yeah. So you could, in year one, you could say, I'm going to work on diabetes prevention. And year two, I'm going to work on mental health. And year three, I'm going to work on obesity reduction. So yes, of course. Can you apply for more than one funding level for more than one program concept? Yes, you can. So if you have the 3 different opportunities that you would like to apply for. One is a level 1, a tier 1. One is a tier 4. You're going to shoot, go big or go home and shoot for that big grant. You can actually put in more than one grant application in the disease prevention grant. So yes, you can. And don't let the numbers intimidate you. Somebody in the chat said that the numbers are intimidating at the larger levels. That was an estimation. We'll just see how the grant funding breaks down. There may be more at that upper level, just depending again on the grants that are requested. Can you win in more than one level? In the theoretical, yes. Our goal will be to ensure that as many hospitals as possible get covered in the granting. So that would depend on how the grants all shake out across the hospitals. All right, any other questions that anyone has? All right, well, thank you so much for attending today. I appreciate your time, your attention. We will figure out how to get this recording as well as the other documents in your hands and ensure that you have those tools ASAP. But thank you so much, and we'll talk again soon.